Hello, you all. Today I am here with yet another topic which is very interesting, and I have a workshop on this. So, I thought why not discuss this topic with you all. It is a pneumothorax that I am going to discuss today. Starting with the definition at first. Uh, what is a bulla? So, this bulla is nothing but it is an air containing space which is more than that of 1 centimeter, and it is a clear cut defined air containing space within the lung parenchyma. Whereas a bleb is an air containing space which is present between the layers of the visceral pleura. You can see here in the diagram. And how do this air enter the pleural cavity? The pneumothorax is nothing but the air which is present in the pleural cavity. Okay. So how does it enter? So this is through a communication between the alveoli and the pleural space. It is between the communication between the atmosphere and the pleural space, and it is a gas producing organism which can be there. So here I have made a diagram which is saying there is this atmosphere and which is entering the pleural space. This is the visceral pleura and this is the parietal pleura, and then we have this alveoli which is containing the air, right, and this is entering into the pleural space. And in normal physiology we all know that the apex of the lung is more negative as compared to the base of the lung. So this is important concept in case of primary spontaneous pneumothorax. We will come to it. So classification of the pneumothorax, it is a spontaneous or a traumatic one. A spontaneous, that means it will happen as a sudden onset event, and it can be a primary or it could be a secondary. Coming to a primary, that means there is no underlying lung disease, and in secondary there is certain underlying lung disease. So we will see what are the lung diseases that are associated. Then coming to the traumatic one, it could be an iatrogenic or it could be a non-iatrogenic. Iatrogenic, that means whenever there is certain thoracic surgeries or any lung biopsies or transthoracic tube insertion procedures or subclavian line insertion. So these things can cause the iatrogenic one, and non-iatrogenic, that is in blunt trauma. Okay. So here I have a diagram made wherein there is this lung and this is the air filled space, okay, and which is actually a pneumothorax, and this lung collapse is because the air is pushing the lung, okay, and this is the normal side. Okay. Now what happens is there is this ventilation perfusion mismatch, and this is causing the shunting. Okay, so this is the phenomenon which will cause the patient to be dyspneic. Okay, and the patient will be tachypneic. He will be in air hunger in case of tension pneumothorax. So we'll come to the clinical features also. Now the reabsorption of the blood gas, okay, the reabsorption of the pleural gas, which is actually depending upon certain factors like the what is the pressure gradient across the membranes, and what is the diffusion property of the gas. So we know that there is a diffusion property which is CO2 more than that of O2 and more than that of N2. So it also depends upon the area of the contact, and it also depends upon the permeability of the pleura. So this is how the air enters, through the pressure gradient, through the diffusion property, through the area of the contact, through the permeability of the pleura. And so we have this 100% oxygen as a treatment for the patient who are under observation. Okay, so there is this primary spontaneous pneumothorax we are going to study. It occurs in tall, thin individuals. Why? Because in tall, thin individuals, the negative pressure is more towards the apex, and they are at the risk of spontaneous pneumothorax. So this is seen in third to fifth decade of patients, and mostly the smokers, but they do not have any underlying lung disease. And the city is suggestive of emphysema like changes. There could be bulla or blebs, and the mesothelial cells are replaced by that of the inflammatory cells. Okay. Then coming to secondary spontaneous pneumothorax. Secondary spontaneous pneumothorax is because of COPD like conditions like the underlying lung disease. It could be because of also any malignancy or infections like PTB, or because of the sarcoidosis, or that of the ankylosing spondylitis, rheumatoid arthritis, any radiation, any chemotherapy, or any of the Langerhans histiocytosis or lymphangiomatosis or interstitial lung disease, cystic lung disease. So these are the causes that can be one of the factor for pneumothorax to develop. Coming to a traumatic pneumothorax. So this is there is a blunt trauma to the patient, and then this trauma which is causing injury to the visceral pleura, okay, and then there could be associated rib fracture to it, and there is air leak that has occurred, and that can cause also damage to the tracheoesophageal bronchial tree also, okay, and there could be a direct leak into the mediastinum. Then there is also esophageal injury seen, and that can also cause hydropneumothorax. Okay, so there are certain mechanisms through which the trauma can cause air leak. Okay, it could be direct visceral pleura, or it could be the tracheobronchial tree, or it could be the esophageal injury. Okay, and this is the visceral pleura, which is main part which is causing the pneumothorax. Then coming to the iatrogenic pneumothorax, so I have already discussed this. It could be transthoracic needle aspiration, or subclavian line insertion, or any transbronchial lung biopsy, or thoracocentesis procedures. And it resolves spontaneously, but the patient has to be kept under observation for a certain period. Now we see the patients who are on mechanical ventilation. There is a chance that whenever a high pressure is given to these patients, and the patient has underlying lung disease like that of a COPD, so there are chances that the patient may have certain bulbar bloods, and that can rupture because of the high pressure, and that can cause pneumothorax. So in ARDS also, whenever we are giving high tidal volume, there is a chance for pneumothorax, right? So this is a chest X-ray. So this is one of the sign, which is the deep sulcus sign, is one of the diagnosis. Now if you see the picture like this, we see that it is a normal X-ray with a certain bronchovascular markings, but you have to notice there is a deep sulcus sign which is present. And then the clinical presentation for the patient will be coming with a pleuritic chest pain, he will be dyspneic, he will say that I am having air hunger, and he will be tachypneic, and he may also have cyanosis because of severe respiratory distress, and it may be even asymptomatic in case of small pneumothorax. And so the symptoms can be even out of proportion, and we need to give him a certain order certain investigations for him, like that of X-ray. Then on the side of the examination, there could be reduced chest movements, there could be absent or decreased breath sounds, and there could be a hyperresonant node as well. Then in case of the X-ray findings, if you notice, there is this hyperlucency that is seen as compared to that of the right side lung, and you see there is this lung, we cannot appreciate lung over here, lung borders, and this is the collapsed lung actually, okay, and this collapsed lung will give us a clue that there is no bronchovascular marking as well over here, and it is a blackish like thing, that is a hyperlucency. Of course there is the deep sulcus sign also seen, right, and this is a collapsed lung, and this is the there is one bulla which is seen in this X-ray, okay. So this will give us the clue towards the diagnosis. But the more efficient part, if you see, so it is the UHG that should be done. So UHG on the M mode, right, so ultrasonography on the M mode. So whenever we see a normal X-ray, there is a lung sliding, that is this called as pleural sliding, okay. Now this pleural sliding means there is this pleura, okay, this is the pleura which is seen, it is moving, okay, and this moving, and this is normally seen, okay, in the UHG, and there are A lines and there is this B lines. ठीक है, this is the B line which is normally seen, this is the A line. Okay, but in case of pneumothorax there is no, pleural sliding is absent and there is no B line. Okay, so we can differentiate. Along with that, there is this M mode, we see a seashore sign. That means this is the water and this is the beach area as presented on the X-ray, and this is the pleural line which is sliding, and this can give us the idea of seashore sign in a normal. But here in the pneumothorax there is no seashore sign, and there is this barcode like thing. Okay, there is a straight lines that are appreciated, and this is a barcode sign or stratosphere sign. Then one more thing is, on the X-ray we will have a lung point. Okay, so this is a lung point which will give us information that yes, here there is certain air which is present, and here there is a normal X-ray if it is a small to moderate pneumothorax. Okay, then we can see this. So it is the edge of pneumothorax, and which is suggestive of pneumothorax. On the CT we can get an idea of the underlying lung disease, the subcutaneous emphysema, or the intercostal drainage if it is inserted. Then we can get an idea, right? Then coming to the treatment. Now when we are talking about the treatment, so in case whenever a patient is with a small or he is asymptomatic, then we can just observe the patient. But in case if it is in a primary spontaneous pneumothorax, and the patient is asymptomatic and it's less than 2 centimeter of the size, then we need to go with the needle aspiration. Now this needle aspiration, what is it? It is like an emergency wherein we just find there is a space in the fifth intercostal space in the mid axillary line where we can insert it, and that will give a relief to the patient. And if there is persistent air leak even after the needle as insertion, then we go with the intercostal drainage. Okay, so first of all, observation has to be done with a high flow oxygen, then monitor if it is a small one, and we can go with the fifth intercostal space needle aspiration with the 16 gauge catheter. Then if there is air leak still persisting, okay, and after 24 hours of X-ray is also done, and then we can remove it if there is no air leak after 24 hours and patient his lung has also expanded. But if it is not, then we have to go with the ICD insertion. The ICD is inserted in the triangle of safety. This is the axillary part which is acting as the apex for the triangle. This is the fifth intercostal this is the fifth intercostal space, and this is the pectoralis major, and the anterior by the lateral edge, anteriorly by the lateral edge of the pectoralis major, and this is the latissimus dorsi which is placed, and that through which the line intercostal tube will be inserted. Now and even in the pleural effusion, if we see, there is this intercostal tube drainage is inserted. Okay, but when we insert a intercostal tube in the pleural effusion, it is seen that it is inserted um, in a downward direction. Okay, because of the gravity, virtue of the gravity. Okay, so fluid is accumulated in the basal part. But when it is seen that it is a pneumothorax, if it is a pneumothorax, then we see it is seen that it is in the upper part. We are noticing the um, tube to be inserted in the upper part. Okay, so this is how we can distinguish between the tube, and we can see that if it is a pleural effusion or a pneumothorax. Then there are certain pleural vent also. So if the patient does not need admission, so this is not used in the government setting, but yes, in the private setting or in the abroad scenes, it is much more common. So this is a pleural vent which has a one-way valve. You will see that it is just a patch or like thing. This is a device which is just put on the chest, and so that it is causing the air to just leak, and there is no air can get inside. Okay, then there is also a Heimlich valve which is a one-way valve. Okay, that is also one way. And coming to the one of the complication that we not aware of is the re-expansion pulmonary edema. Now, what happens when we insert an ICD in a patient? So there is a stress on the capillaries as well, and these capillaries causing increase in the permeability, and thus there is increase in the permeability and there could be pulmonary edema. So the patient should be undergoing supportive treatment with these re-expansion pulmonary edema, and these occurs within that of 1 year or 1 hour of free expansion. Then there is pleurodesis. That means the visceral and the parietal pleura, they get adherent to each other, and that can obliterate the pleural space. This is to we see that this is to prevent the recurrence, and we need to use a talc slurry. So to prevent the recurrence, we need to use a talc slurry. Now the slurry is can be one of the thing is the talc slurry, other thing is tetracycline, or we have the doxycycline, or we can also use the bleomycin. Okay, so that is for the pleurodesis. Now first is we go with the needle aspiration, then with that we go with the ICD, and then also if it is not working, then pleurodesis or thoracotomy, or we can go with the VATS, the video assisted thoracoscopic surgeries, right? So what is the indications for the surgery? If it is a recurrent one, if it is a large bulla, if it is a bilateral or a tension pneumothorax, or if it is a pregnancy, or the lung is not expanding even after the ICD has been inserted, and there is persistent air leak which is more than that of 72 to 96 hours, then we can go with the surgery. Okay, so I have discussed this with the primary spontaneous pneumothorax. If it is less than 2 centimeter, we need to observe the patient. If a patient is symptomatic and more than 2 centimeter, aspiration with a needle, and if it fails, we go with the ICD. Okay, persistent air leak, there is the surgery has to be done, and if it is a recurrence, then pleurodesis, or with the VATS we can go with the further management procedure. Then coming with the secondary spontaneous, so three things we need to understand. If the patient is asymptomatic and he is having less than 1 centimeter of the pneumothorax, we need to observe without of the oxygen. And if the patient is asymptomatic and having 1 to 2 centimeter, needle aspiration, and if it is more than 2 centimeter, go with the ICD. Tube thoracostomy is used in a patient with a bilateral pneumothorax, or in a tension pneumothorax, or in case we have ventilator associated pneumothorax, okay, and in a traumatic pneumothorax. Okay, coming to a tension pneumothorax, we've already seen that what happens in tension pneumothorax is there is this circulatory collapse because the lung is here and the heart is here, okay, and the other lung is here. Now what happens is this lung, which is actually having the air which pushes the that of the heart, and then what happens is heart circulation is compromised, and that will lead to circulatory collapse. The patient will be hypotensive and it is a medical emergency. Okay, so this can happen because of any trauma or any iatrogenic incidences. Okay, and it is causing hypotension and cardiac compromise. So emergency decompression with the needle has to be done, followed by that of tube thoracostomy. So it is important that not only just a needle aspiration, but a tube thoracostomy has to be done. It is mandatory in such patients. Okay, coming to an interesting topic, that is a catamenial pneumothorax. That means during the menses, certain females suffer with suffer with that of the dyspnea and respiratory distress, and that could be because of this pneumothorax, which is occurring within 72 hours of the menses, and which is seen in third to fourth decade of life, and that is because this endometrial tissue goes and relocates into the vesical pleura and damages and causes the air leak. So this is actually causing mostly in the right side of the heart, and there is this catamenial pneumothorax with the hemothorax and with the hemoptysis and lung nodule, which is a syndrome, which is a thoracic endometriosis syndrome. Okay, so we need to go with the surgery, and we can also use pleurodesis followed by hormonal therapy, of course. I hope you have enjoyed this video. I will make sure that I am making more videos that may be helpful for you all. Thank you so much for watching. Bye.